You're listening to the Fertility Docs Uncensored podcast, featuring insight on all things fertility from some of the top-rated doctors around America. Whether you're struggling to conceive or just planning for your future family, we're here to guide you every step of the way.
Hello, everyone. This is Dr. Susan Hudson from Texas Fertility Center with another episode of Fertility Docs Uncensored. I am here with my amazing, beautiful, courageous co-host, Dr. Carrie Vedient from Fertility Center of Las Vegas.
Hello.
And Dr. Abby Evelyn from Nashville Fertility Center. How are y'all doing?
How are you?
Doing good, doing good. It's summertime. It's lovely. Is it super hot outside where y'all are yet?
Hot, but not so humid for us, which is great.
How are the mosquitoes where you are, Abby? Especially because normally the humidity attracts them, right?
Yeah, normally because it rained a bunch. Usually the mosquitoes are really bad, but actually they haven't been horrible lately for whatever reason. I'm sure they'll eventually hatch out and be terrible, but for right now, they're pretty good.
I think it's because they're vacationing in Las Vegas.
Probably.
I think they're in Texas too. Yeah. They're like little vipers right now.
I take the dog out and sit in a corner of my yard while I'm waiting for her to finish her thing. And I have bug bites everywhere. I found a bug bite right in the middle of my butt yesterday. I'm like, this is ridiculous. How did you get into my shorts to that degree?
The desert have mosquitoes and bugs. I thought the desert was hot and dry and bugs don't like that.
So mosquitoes generally don't, but the Aedes aegypti, I'm not saying that right, but the main mosquito that causes all of the big nasty diseases has adapted itself to survive in a very, very tiny amount of water.
Really?
Life will find a way, and mosquitoes have found a way out here. So not only do we have the usual assortment of scorpions, tarantulas, black widows, and other delightful little creatures, but now we have the flying mosquitoes.
Wow.
That's miserable.
That sucks. Yeah. Mosquitoes
Rude.
are awful.
Utterly rude.
I know that they said that if you have a certain blood type, they attract mosquitoes. Is that actually based on any type of scientific evidence, or is that just one of those things that people say?
I think so. It's weird though. I'm O positive, but I don't know if that makes a difference or not. But for some reason, and it may be that my skin is really thin, but if there's 100 people in a room and there's one mosquito, it'll bite me. And I'm not sure why. It's just weird. It's so weird.
I think mosquitoes are attracted to me, but chiggers or red bugs are totally attracted to my husband. The safest place to go if you're walking through weeds is right behind them because none of them will get you and all of them will get him.
See, we have to worry walking through grass. We have to worry about ticks and Rocky Mountain spotted fever and Lyme disease and all that. So I try and stay out of any tall grass with anybody.
Yeah, we have a lot of deer. So even though our grass may be short, they still have chiggers. So
Yeah.
we don't have as many ticks. I remember ticks more being an issue when I was a kid than I do now.
But there's some lone star tick that's supposed to be really pathogenic. And I'm assuming based on its name, it probably is Texas bred. You guys sent them our way, I think.
Yeah. No, I mean, ticks definitely are out there. When my family goes camping, everybody has to check all the places, make sure that
All the warm
that isn't
places
an
the ticks
issue.
could land.
Exactly.
Never thought that I would be appreciative of scorpions and tarantulas.
Yeah, you can see them.
But y'all have just made me appreciative of scorpions and tarantulas that don't go hiding in the dark places. And are leeches
Ticks are
a
in the
thing?
dark places.
Are leeches a
Very
thing
dark.
for either of you guys?
No.
Leeches? No. Well, actually, yeah, in our rivers, we do have a few leeches. I've never seen one, but I've heard people I know in our rivers we do because I know somebody that had a leech on them. Apparently, they're pulled off really easily, though.
I
But
think there are some in rivers, but not to a huge degree.
Yeah,
Like, you
not
could be like a
huge.
serious water sports, like in there a lot type of thing.
Yeah.
Susan, do we have a question? Because I don't like this topic anymore.
We do
This
have a
wasn't where the
question for
conversation
today.
was supposed to go, but hey.
It all works. It all works. If IVF has been living in the I'll deal with it later category, summer might be your window to change that. Schedules shift, things slow down just enough, and suddenly you've got the space to actually figure out what comes next. At Fertility Docs Uncensored, we've spent years helping patients cut through the noise and understand IVF for what it really is. Not overwhelming, not mysterious, just a series of steps you can learn and navigate. That's exactly why we created the IVF Blueprint. It's a straightforward, no-nonsense guide to the entire IVF process. What happens, what decisions you'll face, and how to think through them without second-guessing every move. Whether you've just started to seriously consider IVF or you're already in it and want to feel more control, the IVF Blueprint helps you move from I think I should to I know what I'm doing. You can find it in print, ebook, and audiobook with a bonus conversation from us at the end wherever books are sold and at fertilitydocsuncensored.com. If you've been waiting for the right moment to get clarity, this might be it. Okay, our question for today is, I did 3 IUIs last year. The third one resulted in a miscarriage at 8 weeks. I did a fourth one in September and a fifth one in November. I decided to wait until the new year for fertility coverage, and my last one failed in February. Since it's number 6, they want to regroup. I was really hoping to have 3 in a row, February, March, and April, but now I can't. I'm afraid they won't let me try anymore. I do have 2 older kids and 2 miscarriages these last couple years. I really don't want to do IVF. I just want this to work. So what are your thoughts?
So is it more
Generally,
of a question of 3 in line or just will 3 more work? What do we think?
I think it's more she just doesn't want to do IVF and she's hoping and crossing fingers and toes that everything else will work, even though she's done it for 6 or 7 times.
She didn't tell us how old she was, did she?
She did
She has
not.
2 older kids, though.
Yeah. So it's not that doing IUIs 7, 8, and 9 will never work. It's just statistically it's less likely to. I just saw a study that came out, and I don't know if it was in Fert and Sturt or one of the other journals, but it was talking about success rates up to, I think, IUI number 8. And it showed that they were still reasonable. It's just in many cases, that only takes can you get pregnant into account, not necessarily what is the probability, how much more likely is IVF to work at that stage. And then it sure doesn't take into account all of the emotional and financial and other parts of this world, those components that really play a role in it. Because while, yes, there will be a subset of people who do get pregnant on 7, 8, and 9, most people by the time they get to that point are absolutely fried. They're financially not necessarily getting help from insurance anymore. Or if they are, it means that it's eating away at their benefit for something like IVF that has a stronger success rate ratio. It's a balance of whether or not it really makes a difference. If you know you're never going to do IVF, then sure, go ahead. But it's that balance of what really makes sense to do given your end goals. And all of us have seen people who have done IUIs forever and it doesn't work, or they are just so emotionally depleted that by the time they do come back to do IVF, it's 5 years later, and now their chances have plummeted because of normal passage of time.
Yeah, and I would say reading between the lines, she has 2 older kids. She had 3 IUIs, then had a miscarriage, and has done several more. And kind of piggybacking on what you said, the other issue is if you're 38, 39, 40, maybe you might get pregnant and maybe it might be a healthy embryo. But statistically, even if you get pregnant again, 50% of the time when people have miscarriages, it's due to a genetic abnormality. It may even be probably higher based on your age. You probably know from the last miscarriage, it takes you out of trying for several months until you miscarry and things get back to normal with your endometrium. So I would agree with Carrie. It's probably not going to hurt you if IVF is never going to be an option for you. But I would say at least talk to your doctor about it and get more details about it. It may not be as overwhelming as you think it is. You might have some coverage, and that would be something to look at as well. But probably you're going to have better success if you move on to IVF at this point.
One thing I do want to mention is there was this mention of 3 in a row. And I want to kind of clarify from our standpoint. When we talk about IUIs and recommending 2 or 3 IUIs, that's generally because your momentum is growing in that first, second, third IUI. And after that, success rates relatively plateau. It doesn't mean you can't get pregnant, but you're really not having any growing momentum at that point. A lot of REIs will have a general guideline, not a rule, but a general guideline that 3 is usually the point that we need to sit down and chat, talk about other options, see what we need to do, see if there's any additional testing, anything else like that that's going on. And there's not anything magical about doing 3 back to back. 3 is 3. Whether you do 2 last year and 1 this year, or 1 for 1 year at a time, or however it happens, 3 is 3. Sometimes I have patients who come in who think that it's like, oh, I have to do 3 in a row, or that's the only way that it works is 3 in a row. And that's really not the case. If you need to take a break for whatever reason, I mean, obviously, time is never our friend, which will segue us into kind of our main topic for today. But realize that 3 in a row is just 3 IUI cycles.
Okay.
All right. Well, today we are going to talk about diminished ovarian reserve. So, first of all, what exactly is diminished ovarian reserve?
Really just a low egg count. It doesn't mean necessarily that the eggs that you have are bad, and that's always confusing to patients. It just means that if you look at women that are your age and kind of look at the average number for somebody your age, you have a lower amount of eggs. Your gas tank's half full or lower.
Now, can you have quality issues and that also be considered diminished ovarian reserve?
You can also have quality issues, anything that kind of impairs your ability to be like your peers, essentially.
Okay. And what are the major measures of ovarian reserve? How somebody's ovaries are working?
When we're looking at ovarian reserve, there are the 3 measurable things that we can do in terms of testing. And then there's the 4th, just automatic consideration. So the 3 testable things that when you go into an RAI's office, they're going to start looking at. The first one is AMH. This is a lab test. Very, very helpful because you can draw it at any time. It doesn't really make a difference where you are in your cycle, if you're having cycles versus have an IUD or PMOS where you're not ovulating, things like that. And it's looking at the relative amount of eggs that you have in deep storage. And so we're looking, does this level hit a low, medium, or high amount? And that gives us a relative idea of, do you have very little, average, or a lot of eggs in there? And in general, we're hoping to see a level of 1.5 or greater. But how we interpret that depends on, if you're 40 years old, I don't expect you to have a level of 1.5. In fact, I am delighted if you have a level of 1. Versus if you are 30 years old, really, you probably ought to have a level of at least 2 to 3. And it's that balance. But like all these tests, the AMH level, you don't live and die by it. It's just one piece of information that's coming in.
So, another thing that we look at is FSH. And FSH is a hormone that the brain produces that stimulates the ovaries. And estradiol is what the ovaries produce that feeds back to the brain. Now, when we do this FSH level, we do generally want to do it between cycle day 1 to 4 if you are someone who ovulates on a regular basis. If you're somebody who doesn't ovulate on a regular basis, there's a little more leeway in that. And FSH is not quite as cut and dry as AMH is. There's more disagreement of what's normal, what's abnormal, how strong of a value is it. However, I think most of us would agree that an FSH less than 10 is normal. Something between 10 and 18 is concerning, and over 18, very, very, very concerning. I'll leave it at that.
One thing about FSH too, sometimes we can see people that sort of go in and out of kind of having regular cycles. And sometimes the months where people tend to have regular cycles, even if they've been told they have decreased ovarian reserve, we check those hormones and they're good, particularly in younger women. We don't see that as much in older women. And I think the other issue with FSH too is if it's consistently higher, that tells us this has probably been a problem that's been going on for quite some time. The brain has kind of caught up and realized that the egg count's low and that the estrogen's low.
Can you tell us a little bit about antral follicle count?
So antral follicle count is something that we look at on ultrasound. On ultrasound, we hope to see lots of little tiny baby eggs. So people kind of get confused. These baby eggs, sometimes people confuse with pathologic cysts, and they're not pathologic cysts. They're little tiny eggs on your ovaries. Generally, if you have a really high amount of antral follicles, that gives us some suggestion that you may have a condition like polycystic ovary syndrome, which has now been renamed to polyendocrine
Metabolic
Ovarian
syndrome.
Yeah, it's kind of a mouthful, but named probably better now than it was before. So too much is not necessarily bad, but it does make us think that you may have that. A low number, I would say, and it's really dependent on the age of the patient. But overall, if I see a young woman who has less than 4 to 5 per ovary, I'm a little bit worried about that. And like Carrie said, when somebody's around 40 or beyond, we don't expect to see a lot of antral follicles. If we do, that's great, but it's just that's part of kind of the aging process. We tend to see less follicles in the ovaries.
Carrie, you mentioned another criteria, not something that we necessarily measure per se, but what's that other criteria that can fall into concerns about diminished ovarian reserve?
That's your birthday. And we're not talking about zodiac signs here. So it doesn't matter if you're a Virgo versus a Gemini as to what we think about your eggs. There's no judgment there. But it is how long ago you were born, because eggs have been there our entire lives. Women are born with everything they're going to get. And you start off with maybe 6 to 7 million when you're halfway through pregnancy before you've emerged into the world. By the time you get out into the world, you've got about 1 to 2 million. When you hit puberty, it's roughly 300 to 500,000. And then when you hit menopause, which the average age in the US is about 51, that's got a couple hundred to 1,000 left. And so if we have someone who is 29, that means that her eggs have only been hanging around for the better part of 30 years, as opposed to someone who's 40. All of a sudden, you're talking about 41 years. And that interval makes a huge difference because there's no mechanic that is oiling the hinges, tuning things up within the ovaries. And that applies to the eggs as well. So they've just been sitting there. And in the same way that you wouldn't take a car that's been sitting in your garage for a couple years and assume that the first time you go to turn it on, it's going to work absolutely beautifully with no hitches. If you've got eggs that have been sitting there for 40 years, it's a lot more likely that when you go to turn the key and get them started, that it's not going to work out quite the same way. It doesn't mean that it can't. It just means when you're playing the odds, there's a much higher likelihood that you're going to want a backup mode of transportation for the car that's been sitting in the garage for 41 years. And that's how we look at age. If we've got someone who comes in, if she's 42, even if she is model beautiful, the epitome of health and absolutely perfect in every way with nutrition and exercise and mental health and sleep and every single habit, her age still plays a part because they have been sitting there and there's no mechanic in there putting WD-40 on the hinges.
Every adventure begins with a dream, and for many, that dream is growing a family. At IVF Florida, we understand that the road to parenthood can take unexpected turns. Our team is here to guide you with expert care and advanced fertility treatments designed to support you at every milestone. With convenient locations across Jacksonville and South Florida and flexible monthly payment plans, IVF Florida makes it easier to move forward with confidence. Visit ivfflorida.com to schedule your consultation, because every great adventure deserves a trusted guide. Start yours with IVF Florida. So, other than biologic age, what are some other things that we as REIs, our little spidey senses, start getting a little more concerned about? Hey, maybe ovarian reserve may be an issue. What are some things that we could know about this individual that may make us more concerned about how her ovaries may be working?
Well, one that comes to mind right off the bat is if she's had some exposure to chemotherapy. That certainly can be an issue. Anything that damages the eggs, because like Carrie said, we have one set of eggs, and essentially once that one set of eggs is damaged, there's really nothing we can do about that. And that's why a lot of times we'll have young women come to see us before they get chemotherapy so that we can freeze their eggs and they can use them in the future.
History of smoking is a big one. It is one of the most modifiable risk factors. If someone's getting chemo, it's usually because they didn't have a choice. Nobody just goes on a Saturday night and says for fun, hey, let me have some chemotherapy. Smoking is a modifiable one. And it is one of the very definitive factors that people can control that influences age of menopause. If someone's got a history of smoking, even if they're not smoking right now, in the past, we know that those eggs have seen a little bit more of an insult than if someone is not a smoker.
So if we maybe have had a patient who has maybe ovulatory dysfunction like PMOS, or somebody who has endometriosis, and they have crossed the paths of other physicians in the past, what are some things with those types of people that may make us more concerned?
So, if patients have had surgery, particularly if they have an endometrioma in the ovary, and endometrioma is a collection of endometriosis that grows in the ovary, that typically means that you have a more advanced version of endometriosis. Often, in order to really fix whatever the issue is, like if you're having pain, generally most physicians, if they're going to go in surgically and they see an endometrioma, they're going to want to remove it because you're just draining it doesn't really do the job. So, in order to drain it, they have to cut through normal ovarian tissue. They have to dissect out the wall of that sac and pull that cyst out. And endometriosis tends to have lots of blood supply. It tends to be a fairly vascular surgery, lots of bleeding. Oftentimes, a physician has to coagulate or stop that bleeding. In doing so, unfortunately, there's lots of little eggs in there that may be damaged. Many years ago, we used to do that often. Now we do that less often unless the endometrioma is really large, 3 or 4 centimeters or greater, or if the patient's having a lot of pain. We try and leave the ovaries alone, particularly before we do IVF, because if we're going to aspirate eggs, we want to get those out before you have damage from the surgery.
So sometimes people with PMOS can have a surgery where essentially they go and burn some of the ovary away to reduce the egg load to encourage more natural monthly cycling. And though it sometimes can work, and it's not done as much in the US as it once was, I still have some patients who come from other countries on a regular basis that have had this done. And those are people that does make me more concerned. What are some other health conditions that make us a little more concerned about ovarian reserve?
There's a genetic condition called Fragile X that we screen for, especially if someone comes in and they have a lower ovarian reserve than what we would anticipate for their age. And Fragile X is a genetic condition, and it is a instability in the X chromosome. There's these little things called repeats, and think of them as the little three-pronged Lego blocks. And instead of having 5 of them, for example, and these numbers are not true to force, but instead of having 5 of them, maybe you've got 10 of them or 20 of them. And having those little really short blocks in there, the more and more you have, the more unstable that chromosome is. And there are people who have a full-on Fragile X syndrome that is related to decreased mental capacity. There's a movement disorder associated with it. One of the things that can be associated with it is decreased ovarian reserve. Many times people will come in and we'll be doing these screening tests and they don't have full-on Fragile X, but they've got what's called a premutation, where instead of having a huge number of these extra little Lego blocks, they've got a moderate number. And we want a small number. So they don't have the huge amount. Doesn't mean that they have the condition. It means that that X chromosome is more unstable. And one of the offshoots of that is having an earlier age at menopause. So when we see that in people, we tend to jump a little bit faster of maybe we want to do a little more fertility preservation, be a little bit more aggressive, think about that second or third child that's desired now rather than letting it go, even if someone is young and we would otherwise not be terribly concerned about that. In the presence of Fragile X mutation or premutation, we pay more attention to that and we're a little bit more mindful of what can happen in the future because they're not necessarily on the same timeline as someone who is not affected by that.
Also, if you have any autoimmune conditions, the most common reason other than age for us to see somebody with diminished ovarian reserve is that just their ovaries are not acting the right age. And a lot of these people have other autoimmune conditions, whether it's celiac, Graves' disease, Hashimoto's, ulcerative colitis, Crohn's, psoriasis, to name just a few of them. But realize that autoimmune disorders travel in packs. And if you have one, you're at an increased risk for another. So if you have an autoimmune disorder, being aware that your ovarian aging may, not always, but it may not go along the normal timeline is a possibility. So say somebody has diminished ovarian reserve and say we have mild to moderate ovarian reserve issues. Nothing as an REI doctor we're super, super sweating about, but we see that this is going to be a little bit of a challenge. How do you advise those people for this pregnancy and future pregnancies?
Well, I think it's important for women to really know what family size is important for them. Some women are happy with one child. Some people want a basketball team. If somebody in that situation wants several pregnancies, her age that she is now is the best her egg reserve is ever going to get. The older she gets and the more she ages, the less likely she's going to have good embryos that are genetically normal. I think if you're somebody that just wants one baby, then maybe you don't have to do anything too aggressive. But I always worry when I see somebody with a low egg reserve because I don't know when that process is going to come to completion and when you're not going to have any more eggs. So often we'll advise patients who want multiple pregnancies to think about freezing eggs, going through IVF, either creating embryos or freezing eggs for future use because those eggs or those embryos don't age, whereas you continue to age. Then if you have two or three genetically normal embryos, you may go, that's great. Maybe my partner and I will try on our own right now and then use those eggs or embryos at a later time.
One thing I want to insert is when your REI asks you about how many children you would ideally want to have, I always preface it with, in your ideal world, not the world where you're sitting here talking to me. And it's because we want you to tell us your honest truth. Because when we're coming up with plans and recommendations for you, if you're one and done, which is completely fine, I'm an only child. I completely respect that. But seriously, if you truly only want to have one child, that is completely fine. But don't tell your REI one when in your heart of hearts you're thinking two, three, four, because there's different things that we're going to counsel you on, and no one's ever going to hold you to it. But it gives us an idea of if you have diminished ovarian reserve, are we looking at really focusing on this one, or do we need to focus on this one and also have some more thoughtful conversations about those future babies?
If you say 3 and then later change your mind to 1, we are not going to force you. We're not going to hunt you down and bind you and say, look, you promised us 2 more children. It's really just kind of getting an idea. You're totally entitled to change your mind. The other thing about that is when we ask that question, we are not asking how many kids do you want at one time. Our plan is always one at a time. That is safer for you and safer for baby. This is not saying, do you want a singleton, twins, or triplets? This is saying, do you want baby 1, 2, and later 3, or are you thinking about just 1? Because sometimes I think people read that question in a different way than we are intending it.
So say somebody comes in and they have pretty bad ovarian reserve, and we're going to just leave it at that. We're not going to attach any numbers to it. And they come in and they're like, what do I do now? How do you break down the most common treatments? And how do you advise when is the right time to go where?
Wow, that's a big question. I think it's really dependent on the patient. I mean, as a physician, when I see those numbers, I try not to show panic, but sometimes I feel panicked if the numbers are really low. But I've also seen, and I learned this over many years, I've also seen patients that you think for all the world they have such a low egg count, they'll never get pregnant, and they get pregnant with the first IUI cycle. So
We never say never.
yeah, you never can say never, and you never can predict how somebody's going to do. I lean toward trying to encourage in my patients to be a little bit more aggressive, or at least at minimum, if they're going to do IUI cycles, let's do them, even though we talked about earlier, you can do them at different times, but let's do them pretty closely together. Let's figure out if that's going to work or not. If it doesn't work, then let's pretty quickly go to something more aggressive that may work more quickly and be more effective.
What are some of those more aggressive treatments?
Sometimes when people come in, they're thinking about just doing ovulation induction with plain old Clomid. And then the next step up from that is adding trigger medications, monitoring IUI. And the next step up from that is doing maybe an ITI where it's an intratubal insemination. And then the next step up from that is doing IVF, where we're giving much stronger medications to encourage as many of those little eggs to grow at a time as they can. Not because we want to deplete your entire ovarian supply in one cycle, because it doesn't work like that, but because we want to take advantage of maybe instead of 1 egg growing, which is what it would do on a natural cycle, we have 4 or 5 or 9 or 10 or whatever number we can get come out all at the same time. Now, there will be some patients where when we run the numbers on all of those things, trying to use their own eggs is highly unlikely to work, or will take quite a high number of cycles to do. And some patients say, look, I would love to be able to do 10 cycles of IVF, and that is absolutely not reality. And I have one cycle to do this, whether that is financially, physically, emotionally, because there are plenty of people who may have the bandwidth to do it financially, but just emotionally, they can't do it anymore. They've already spent 5 to 7 years before they got to us struggling, and they're not in the market for that particular struggle anymore. And so in those cases, someone may decide to go to a donor egg or donor embryo in order to bypass some of the issues that the eggs may have and trade on their strengths, which is usually in these cases, the uterus and oftentimes general health are totally fine. So decreased ovarian reserve is not necessarily a problem of carrying the pregnancy. Once you get to the pregnancy, it's totally fine. And they've got the same success rates as anybody else who would do well. But getting there is the problem. They may decide, I am done with this deal and give me a donor egg or a donor embryo, and we're going to move on and just get pregnant and go from there.
Something I want to dive into a little bit deeper that you alluded to. So if I'm going to go through IVF and hey, I have diminished ovarian reserve and I'm emotionally with it and I have all the finances and life is full of roses, but my ovaries just are not great right now. If I do multiple IVF cycles, explain to me, why am I not using up all my eggs?
The reason you're not using up all your eggs is when we stimulate you, we try to get a year's worth of eggs. In Susan's words, we try and get a year's worth of eggs if we can. Oftentimes, if you have diminished ovarian reserve, low antral follicle count, that might be anywhere from 1 to 3, 1 to 5 eggs. Ultimately, when we start to stimulate you, eggs we think come along in batches. Every 2 to 3 months, there's a new batch of eggs. When we start to stimulate you, all we're going to really stimulate is the batch of eggs that are available to us, large enough to kind of take the FSH medicine and start to grow after being exposed to it. So you still have other eggs that may come along in other months that are not available at that time, but we take advantage of the eggs that would normally be atretic and go away on their own. And we hope that we can get them to stimulate to the size where we can actually retrieve a mature egg from them.
If somebody has diminished ovarian reserve or they're concerned about it because maybe they're in their upper 30s, early 40s, something like that, what are some of the adjuvant therapies, supplements, other more fringe things that are out there? Which things have some data behind them?
CoQ10 has got some data behind it, 400 to 600 milligrams a day. We want you to be on it for at least 2 to 3 months if we have that flexibility. We don't always, but most of these things that we're talking about, ideally you're on them for at least 2, if not 3 months, because as Abby was mentioning, that's the lead up time for these follicles or eggs growing, and we want them to be exposed to whatever we think is beneficial in that time. So if you're stopping smoking, if you're taking a supplement, that's the time frame we're generally hoping for. Longer is better, but that's the minimum that we're going for. So CoQ10 is a very popular one that you can get over the counter. You do not need a prescription for it. They sell it in every possible place that sells pills, supplements, and even some of the places that don't sell pills and supplements, they still have them. And that's probably the most common one that we hear about.
What are some other things out there?
So there's something known as NAD plus, just like CoQ10 is sort of a longevity supplement, but this was initially marketed as a longevity supplement. It also works in the mitochondria in the way that CoQ10 does. It's one that's kind of low on the radar, but I've had more and more patients lately ask me about it, and it works in a different place in the mitochondria as compared to CoQ10. I think it's worthwhile to try that as well. Other things kind of outside of supplements would be things like acupuncture and yoga. And there's not randomized prospective data to really show that acupuncture and yoga are helpful. And with acupuncture, you can find studies on either side, but I think at minimum, it helps with relaxation, helps decrease your levels of anxiety, which helps get rid of all those hormones that are problematic, like cortisol, those stress hormones. Yoga can do similar sorts of things as well. I think both of those would be helpful as you're going through this process too.
So I have a question, and I may be like digging myself in a corner here because we don't personally do much of this at our practice. But any of y'all have any experience with PRP?
A little bit. There is no data on that. Richard Scott has actually published a paper on that. There is no data that shows that PRP or platelet-rich plasma is helpful. And essentially, that's where they spin down your own blood until you get to a really rich part of the plasma that has growth factors and things like that. In theory, it can either be injected in the ovary, it can be flushed into the uterine cavity. But either way, there's not really great data that shows that it's beneficial, and it's probably pretty expensive.
It's also invasive, particularly if you're injecting it into the ovaries, because it's an egg retrieval cycle in reverse. And there's potential you can introduce infection in there, and you're introducing something into the ovaries. And if you compromise it in any way, hit a vessel, hit whatever, then there's a concern of, did I do more damage? And it's becoming more and more popular. We're seeing it more often. We're not just seeing it in the fertility world. If you've ever heard of a vampire facial, that's PRP, because you're taking your own blood, spinning it down, and then they're re-injecting it usually into the face, and in hopes that it's going to have a significant improvement. And I haven't read the data on that, so I have no comment one way or the other of whether or
You
not.
haven't gone to
It
no
seems
vampire
safer,
facial for you?
though.
No vampire facial for me. It's becoming more and more common. We hear about some of our counterparts doing it, and it's one of those things where it doesn't have great data behind it, and it's expensive, and there's more potential risk to it than just taking, let's say CoQ10 doesn't do anything. Well, so you're taking a supplement a day. It's relatively cheap, it's relatively easy, and the negative impact is quite small if there is a negative impact. With something like PRP, it's more actively invasive. The penalty, if you do hit one of those small percentages of negative outcome, is considerably higher. We don't do a whole lot of PRP, although there's certainly plenty of REIs out there who do it.
All right. Any other thoughts about diminished ovarian reserve that we haven't touched on today?
Well, I think it's just emotionally, it's a really tough diagnosis, particularly for young women to get because they're not expecting it. And I think the one thing you should think about is your egg quality is probably really good. It's just you just don't have a lot of eggs. As I said earlier in the show, I've had a few patients that I've just been shocked. They do one treatment cycle and boom, they're pregnant and they have a diminished ovarian reserve. Don't think of it as I'm never going to have a baby that's biologically my own. Don't think of it at that at all. But I do think that it needs to be addressed by your physician, and maybe you need to be a little bit more aggressive with treatments because you don't have a good pool of eggs.
The other thing that I would like anyone who's been diagnosed with DOR to do is raise your right hand, repeat after me. This is not my fault. And
Yes.
you didn't do anything to cause this. It's just how you're wired. And even if every single other person in your family is having a baby into their 40s, but that is not you, you didn't cause this. You're not being punished for anything. This is not your fault. And many people take it personally. And they think, oh my gosh, I did something wrong. I did something bad. And the answer is no, you didn't. You're a human and there's variations among human, and you happen to get the short end of that particular trait. We make the best of it that we can. And all of us have had people who've gotten pregnant without us thinking that that was a very high likelihood. And just in the same way that the opposite can happen too. It's not your fault. Please have very little hesitation in going to see a therapist, a counselor, somebody who can be objective from the outside that can help you remember that, because this can be a very hard diagnosis.
Very well said. Very well said. All right. Well, to our audience, thank you so much for listening, and subscribe to Apple Podcasts to have next Tuesday's episode pop up automatically for you. Also, be sure to subscribe to YouTube. That really helps us spread reliable information and help as many people as possible.
Visit fertility.uncensored.com to submit specific questions you have and sign up for our email list. Check out our book, The IVF Blueprint, at all major booksellers, Amazon, Barnes & Noble, bookshop.org. Also catch us on Instagram or Facebook for another quick hit of infertility.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. Subscribe, sign up for emails, and we will talk to you soon.